Paul Auwaerter with Medscape Infectious Diseases. Last month, I had the pleasure to attend the European Clinical Congress of Microbiology and Infectious Diseases held in Copenhagen, and I thought I'd just touch on a few things that caught my interest. Obviously, this is idiosyncratic. It's a huge meeting, over 14,000 attendants, and many excellent sessions and posters. Among those that I would just give very quick mentions to was the rather remarkable effects of the pandemic on invasive group A strep infections. A presentation from data in the United Kingdom from 6 years dating back to 2022 found that on average there were 350 cases per year per pandemic, but in 2021 fell to only 29, but then rebounded last year in 2022 to 690, clearly reflecting the impact perhaps of social mitigation measures, perhaps the influence of the lack of viral upper respiratory infections that might drive invasive streptococcal disease. There's also increasing trends in tetracycline, erythromycin, and clindamycin resistance, perhaps relevant for your considerations when treating severely ill patients who might be penicillin allergic. Of course, all isolates were still penicillin sensitive. In terms of new drugs, I'd mention ensitrelvir, a novel protease inhibitor that does not require ritonavir, that's already received emergency use authorization in Japan for COVID. So this protease inhibitor of SARS-CoV-2 had some data which was presented from phase 3 trials that suggested that there was sound inhibition of virus with lack of detectable virus and shorter durations of viral culture. And amongst 70 patients who were asymptomatic were placed on the drug with infection, fewer had symptoms compared to placebo. This drug has received fast-track authorization through the FDA, additional clinical trials in progress. Two bacterial drugs that you may be hearing about soon. One is gepotidacin. This is a novel drug that inhibits DNA replication by binding to two different topoisomerase inhibitors, somewhat similar to the fluoroquinolones, and has broad spectrum activity, including gram-positives, gram-negatives, anaerobes, as well as, for example, Neisseria gonorrhea. Data from 2 phase 3 trials were presented, non-inferiority trials in uncomplicated UTI compared to nitrofurantoin. Of course, it compared well there, and that's probably not surprising from that standpoint, but this was one of the first trials I've seen with the new composite endpoint in uncomplicated UTI from the FDA, which is a composite, both clinical and microbiologic success. And that composite endpoint scored far lower at 50 and 47% in the two, so it was non-inferior, even though their clinical and microbiologic success rates independently were higher. But interestingly, 98% of the enrollees did not require an additional antibiotic. So the meaning of this new composite metric is indeed interesting, and whether it's still a worthwhile approach moving ahead is something that remains to be seen. One that I think may be useful is a new combination drug called sulbactam durlobactam. Sulbactam, of course, has been a component of ampicillin sulbactam, but durlobactam is a novel beta-lactamase inhibitor with the idea that it can treat some carbapenemase-resistant organisms, but also Acinetobacter, because globally it looks by in vitro studies and collections that there's only about 4% resistance. So they had a phase 3 trial looking at colistin-resistant Acinetobacter resistant infections and also those in general, and found that it performed better than colistin, looking at mortality, clinical cure, microbiology cure, as well as having less nephrotoxicity. Now, admittedly, comparison with colistin is a pretty low bar to achieve, but this drug will be reviewed by the Food and Drug Administration later in May of 2023, so we'll get a closer look at the data and see how that might stack up and whether this drug may have a place in some incredibly difficult to treat infections such as Acinetobacter. And I just close briefly by one of the keynote lectures given by Thomas Harrison. I just thought this was a remarkable story of over 20 years of lots of work in Africa on trying to improve the treatment of cryptococcal meningitis. And in these low resource settings, over a period of many years and trials, he was able to move from the gold standard of 2 weeks of amphotericin with 5-FC to oral fluconazole to a shorter course of amphotericin of only 1 week with 5-FC. And now, most recently, last year, published a study harnessing the long half-life of liposomal amphotericin B such that a single dose of liposomal amphotericin V plus 5-FC and then fluconazole was non-inferior to more extensive regimens. And overall, not only lowering costs and the ability to infuse an intravenous drug in a low resource setting, but moving mortality from over 75% to perhaps 25%. Truly remarkable and a testament to not only Dr. Harrison, but his active clinical trial team and many others who were dedicated to improving care in often challenging settings. So thanks so much for listening. Hopefully this was of interest, and stay tuned for additional Medscape videos and blogs. Thank you.